questions, so you know. Good afternoon, everybody. This is Dana Harganani, Chief Medical Officer with the Oregon Health Authority. It's September 3rd, and it's our OHA COVID-19 webinar series for healthcare providers. And before we get started any further, I want to share an apology that 2 weeks ago we had to cancel this webinar last minute as we had an entire network outage right at the time that our webinar was supposed to start. And we unfortunately had no alternatives to pull off in a quick manner. So apologies for those of you that were waiting for us. We hope that doesn't happen again in the future. So today, again, we're giving our biweekly OHA update for healthcare providers. And I'm joined by Dr. Tom Jean, Deputy Public Health Officer and Epidemiologist, and Dr. Ariel Smits, our Health Evidence Review Commission Medical Director. Both who are playing roles as senior health advisors on our COVID response. So we are going to get started today, and today we're going to be trying to broadcast the questions that you are sending to us on the webinar so that you can see them. We haven't used that technology yet, so please bear with us. And we will try to respond to as many questions as we can throughout the webinar. Okay, we'll get started here with our agenda items. We're going to do our normal situation update with some of the most recent data we have. Going to spend a few minutes focusing on the data in some of the responses related to the disproportionate impact of COVID-19. We're going to give you some information on a recently published seroprevalence study from Oregon, provide some testing updates, as well as some national guideline updates. And then we'll close with some literature review and answers to questions that have come up previously. So just starting with our situational update, as of yesterday, September 2nd, we are now over 25,000 total cases of COVID-19 in our state, and a bit over 2,000 hospitalized cases, and a total of 468 deaths, unfortunately. The positive news that we are excited to share today is that we've seen cases slowing down. You can see that as represented on the epi curve here at the bottom. And we'll talk to you a little bit more in the next slide. The total daily cases have been declining, as well as hospitalizations, which are represented in the blue bar at the bottom of this epi curve. So looking at the most recent week of our most recent epi week, August 23rd through 29th, we had just over 1,500 new cases recorded. And as I mentioned, this is a trend downward that we're excited to be seeing. We are down 8.6% in terms of total cases from the week prior. And so far, it represents Oregon's lowest weekly total since the end of June. I would also note we just will be, I believe, having our modeling data posted on our website by the end of today. And right now that modeling is showing that we're running at an R0 of about 0.9, consistent with the cases slowing down. And while we didn't have that modeling data ready to share with you, we invite you to take a look at it on our website. Again, we anticipate that is posted by the end of the day. And again, consistent with some of the data we're sharing with you today. Of last week's test results that have come in so far, 4.4% of those tests were positive. And the age group with the highest incidence continues to be those young adults aged 20 to 29. As you might recall that we've been presenting recently, these numbers may continue to change because we are focusing our weekly epi data based on the time the specimen was collected. And so there could still be some lagging results coming in that could change the overall number of cases for this epi week, as well as the percent positive. But overall, we're seeing day over day generally improvements in the number of case counts in our state and the percent positive at test results. I'll pass this to Dr. Jean to talk about school readiness metrics.
Thanks. Yeah, so school is on everyone's mind right now. Many schools have opened or are about to open. And, we've had, I think you're all aware, we have metrics that we work closely with ODE on, the Department of Education, to determine where in Oregon and where schools can reopen and how they reopen. So we have these, it's a little bit complicated, but if you go to the ODE website, you can see the metrics explainer, which kind of is a 3-page summary of the criteria, including some of the exceptions. But there's currently a state level and a county level threshold that we're not actually meeting at the state level next. So next slide, and we can see that. So happily, we are below. There's 2 criteria at the state level, or there's 2 criteria at the county level. At the state level, we are below the 5% threshold for test positivity for the preceding 7 days, so that's good news. However, many counties are not below their threshold of less than 10 cases per 100,000 population, and then the test positivity in their county of less than 5% over the previous week. In many of these counties, especially the rural and smaller population counties, there are some exceptions that would allow smaller schools to reopen for in-person or hybrid learning. So local public health is working with those school districts to make sure they have a plan and that it's appropriate for them to reopen with some in-person instruction. But in most of the larger counties, schools are going to be distance learning for now until numbers come down. So that's kind of the summary of school.
Great, thanks, Dr. Jean. Here you just have another snapshot of what's going on with our current hospital census regarding COVID patients who are hospitalized. We know this is a lagging indicator compared to new cases. And as you can see here, these trends kind of mirror what we would expect based on the trends we're seeing in new cases overall. So we had kind of a peak and plateau from mid-July to mid-August in increasing COVID hospitalizations here in Oregon and patients in the hospital. And then you can see a pretty sharp decline that's occurred over the last 1 to 2 weeks. We continue to monitor this closely, but are certainly reassured about this as another indicator of improvements and certainly help in terms of hospital capacity. You might remember this is looking statewide. The top line are all patients who've tested positive for COVID in the hospital. In the middle line are the proportion of those patients requiring ICU level care. And the bottom line are those proportion of patients requiring mechanical ventilation. We know that hospitals continue to be full for other healthcare needs from our Oregonians across our state, as can be true this time of year with traumas and other, but they are maintaining hospital capacity. And again, fortunately, impact of serious COVID cases has not been an additional big stress on the system over these last couple of weeks. So I'm going to stop and just ask a question. I'm going to try here to broadcast it to the group. I think that worked. And I'm going to ask Dr. Jean if he could answer this one before we move on about school metrics. So the question is, regarding school metric exception for kids with special needs, are there any metrics precluding in-person instruction for those specific kids?
So that's a good question. There are some exemptions for limited in-person instruction for specific groups, including students experiencing disability and English language learners, and then some career technical education. And so basically there would have to be no confirmed cases among school staff or students in the past 14 days. And of course, we're just starting school right now, but that's one of them. The schools need to comply fully with the Ready Schools Safe Learners guidance, and they need to be otherwise complying with the comprehensive distance learning guidance, which has some limitations on cohort sizes, time, and more. So the answer is, yes, there is that kind of, there's nothing precluding a school from doing that kind of special education in as long as they're meeting those requirements. I hope that was clear.
Great, and Dr. Dean, I'm presuming these are all on the ODA website with the link that we provided.
Yes.
Great. Okay, moving on, we're going to just talk briefly here, sharing some of the ongoing and most recent data regarding the disproportionate impact of COVID-19 and some of the resources available trying to address this impact. So here you've seen this data before. This is the most recent data through Sunday as reported in our weekly report. And at the top, you can see COVID cases per 100,000 population by race, and at the bottom by ethnicity. And as you can see here with the highlighted yellow, this is the area where you can most readily see that disproportionate impact. And in particular, you can see that is particularly notable for Black African American population, American Indian and Alaska Native, and Pacific Islander populations in our state. I've shared before the other here, although on the race category, we believe the majority of these are actually representative of those people who identify as Hispanic. So when you look down at the next table, this is the impact of COVID-19 by ethnicity. And again, here you see the very notable disproportionate impact of those who identify as Hispanic or Latinx here on the slide. We've continued to monitor this closely and working with many community partners across the state to identify what needs and supports can be offered during this difficult time, recognizing that some of these impacts are due to longstanding historical inequities that impact health. So a couple of the resources I wanted to share with you so that you're aware. One here is actually something we shared before. This was funding that the agency has made available to partners from community-based organizations to help the state respond to COVID-19 in culturally and linguistically responsive ways. So this is basically just a reminder and an update that these CBOs that we've contracted with are helping in one or more of the following ways. In helping to do outreach and community engagement in their communities, supporting contact tracing in coordination with local public health authorities, and providing people with social services and wraparound supports or connections to those. There are funded organizations in every county in the state, and these organizations have deep ties and trust with the communities they serve. And you can see a list of the funded CBOs on our website now. This is just an update since I last talked, so you can go look up and find out what those community organizations are that have been funded and access and connect with them should you have a need or whether that can be helpful in supporting the populations you're serving. So take a look there, and this has been an important part of our response. Also, I wanted to share a new opportunity that's just been announced, and we're now reviewing applications that were submitted. So a couple weeks ago, OHA opened grant applications again to not-for-profit organizations statewide, as well as Oregon's 9 federally recognized tribes and the Urban Indian Health Program, or NARA. These grant opportunities are intended to address the disproportionate impact the COVID-19 pandemic continues to have on Oregon's tribal communities and communities of color. And the funding for these grants come from the CARES Act dollars received by our state, which were legislatively directed for this particular purpose. In all, a total of $45 million is available. And specifically, these grants are intended to address the social determinants of health that play such an important role in the disproportionate impact from COVID and other health inequities. So these grants can be used for a broad number of things that reflect areas such as health and economic disruption, food insecurity, housing, safety, violence prevention, and wage relief, all as related to impacts right now from COVID. The applications were due on August 31st. And I have just learned that we've had over 350 applications for these grants, which we are thrilled about. And a review of those applications and consideration for decisions are underway. So if you'd like to see more information about this opportunity, please take a look here. And as we have funds available and those decisions are made, we'll be able to share more information about the organizations and what was funded, again, as connection points for populations that you serve. And then I briefly wanted to share these other two important resources. Admittedly, these are not state-specific resources, and I'm not an expert in these, but they are critically important opportunities led by coalitions in our community of more than 100 community partners. And I wanted to make sure you were aware and had the website to go look at this again if this is useful to your community. So the Oregon Worker Relief Fund assistance is administered by the Oregon Worker Relief Coalition, and it provides temporary aid to undocumented immigrants who lost their wage because of the pandemic. In this COVID response, unlike others who've lost their jobs as a result of COVID-19, many immigrants were excluded from any federal aid, unemployment, and other safety net programs. And this particular fund assistance is dedicated to addressing that gap. So any Oregonian 18 years or older who lost their wage because of COVID-19 and is excluded from that safety net of federal resources because of their immigration status can apply with these funds. And sorry, they are open. I should have, this is a miswording on this. So this is the website here at the bottom that you can connect people to, should that be a need that you are identifying. This is a bit old now, but what I could find from the coalition, this was impact as of just over a month ago. This coalition had delivered over $12.6 million in disaster relief throughout Oregon's immigrant communities. You can see this report. I have the link on here at the bottom. And the types of recipients, the types of work that they work in included primarily food service, but also janitorial and housing, construction, childcare, agricultural, and beyond. So again, a resource that you should be aware of for the community, and a list of the large number of organizations that are supportive and part of this coalition. And then I also want to mention the Oregon Quarantine Fund, also similarly administered by this coalition in support with public dollars and working in collaboration with the state and the Office of the Governor. This quarantine fund specifically offers financial support to farm workers who self-quarantine after being exposed to COVID-19. Again, I've listed here who is eligible. And I would invite you again, if you're hearing of this need and resource, to be sure to connect to this website and share this information broadly. Okay, I'm going to move on now to Dr. Jean, who's going to talk with us about the Oregon seroprevalence study.
Okay, so we recently published, next slide please. We recently published a, next slide. Dana.
Sorry.
We recently published in the CDC's journal, the MMWR, some analysis of serology study here in Oregon, and I wanted to talk a little bit about the results that we found. So basically what we did, and I wasn't actually part of this group, but some of our senior health advisors were, we looked at random samples of de-identified blood from patients of all ages, basically visiting any outpatient or emergency, urgent care, or inpatient healthcare setting. And that was drawn from 19 facilities that are already participating in our ILI-net or our Essence surveillance system, which is for, again, for emergency departments and urgent care. So we had a total of about 900 samples collected in May and June. And we used the Oregon State Public Health Lab and the Abbott IgG serology assay, which is one of the best in terms of sensitivity and specificity. Next slide, please. And here is the table with the main results in terms of the number of specimens tested by age group and the number of positives. So you can see we had a total of 9 positives, people who had the antibody, the IgG antibodies for SARS-CoV-2, 9 out of about 900. So just about 1.0% of the total population. And even though the sample size is relatively small, you can see that there's a clear pattern of increasing seroprevalence with age, especially above age 65. The highest age group was 75 to 84 with a 2.1% prevalence in Oregon during that time. Next slide. So again, the estimated prevalence was about 1.0%, which is approximately 10 times the measured COVID-19 incidence that we had from our surveillance of PCR testing basically during that time period. So that suggests that a substantial number of our cases have gone undiagnosed, not reported, and that, of course, a large population of our, 99% of our population at the time is susceptible to COVID-19 infection. Not really surprising findings. It was, I would say, kind of expected, but really good to have this hard data of what our prevalence was at that point in time. And there's a link to the MMWR article if you'd like to read it. It's pretty short. Next slide. So moving on to some testing updates, we wanted to address antigen testing today. Next slide. So I think we've talked about antigen testing a little bit in the past, but just as a reminder, there's basically three types of testing. There's PCR or nucleic acid testing, which is the gold standard. There's antigen testing, which is also a test that looks for active virus, but it's looking for an antigen or a protein or a part of the virus, a little different from the RNA amplification method of PCR. And then the third type is antibody testing. So just so we're all on the same page, we're talking about antigen testing here. So the sensitivity of antigen tests, which are usually pretty rapid tests, is generally quite a bit lower than PCR, or a little bit lower in some cases than PCR. So PCR remains the gold standard. And there's currently now, I just checked, four rapid antigen tests that received emergency use authorization from the FDA. And they are limited in their EUAs to diagnostic testing on people with symptoms within 5 days for a couple of them and up to 12 days of symptom onset for one of them. So when these are used for screening testing, it's important to note that the results should be considered presumptive, and that would be screening of asymptomatic people, which is what some people are proposing. When they are being done, people with symptoms, we actually consider here in Oregon a positive a confirmed positive because they are quite specific. All right, next slide, please. So I wanted to make a table here comparing these four tests, and just so you can see some of the important points about them. The first one out was the Quidel Sophia 2, then there was the BD, there's one called Bumira, and then most recently we've had this Abbott Binax now. They are all point of care tests. I believe they're all lateral flow, so it's a pretty simple technology, but a machine is required to interpret the first three. So you can't just do it at home. It has to be done under a clinician's care when they have to have the machine. The new one, the Abbott Binax now, does not require a machine. It's basically a card, and you take a nasal swab and you put it on the card, and then there's some indicator bars, kind of like a home pregnancy test. And those are supposedly only $5 each. You can see the sensitivity is actually pretty good for most of them. The BD not quite as much, and the specificity is 100% or close to 100% for all of them. And again, that factors into the lack of many false positives, which is important. We don't want tests that are giving us false positives. And then another point is that none of these has really been tested in asymptomatic people. The Abbott one did have 7 out of 102 in their little study that were without symptoms, but that's not really enough to validate it for screening of asymptomatic people. And the rest were all tested only in people with symptoms. The Abbott was not tested in children, which is another concern, because as I'm about to get to, the federal government is distributing those to schools, among other sites. So definitely some concerns there. But I think these are going to be an important part of our overall testing strategy. Next slide. Just wanted to show some of the advertising for the Binax now, and this is what the card looks like. And they have an accompanying app acting as which you can see here. And on the next slide, you can see that they're yeah, next slide, that they're kind of advocating for this temporary mobile pass. If you have a negative result, you could show this pass to somebody and say, look, I tested negative. Now, I think there's some concerns with that. They've got this little expiration date here, which would imply that you're good for a certain number of days after a negative test, which is not the case in terms of you're obviously susceptible at any point. A negative test doesn't mean you're somehow protected against COVID. So I have some concerns with that. But again, the federal government has bought, let me see here, 150 million of these tests with a contract, and they'll be distributing them to governors to support opening of schools, daycares, and also out to some assisted living centers and home health staff. So you'll be hearing more about those.
And Dr. Jean, I'm assuming that as this becomes more available, we can take the opportunity to address that somehow in our testing guidance ahead, just to... Yeah.
So we are kind of evaluating this. It's pretty new. We're waiting to see what we get here in Oregon, but I just wanted to highlight because this has been in the news in the past couple days. I don't want to spend too much time on this. I've kind of addressed this. This table shows some of the differences between PCR and antigen. One of the main differences is that PCR is more sensitive, antigen is less sensitive. The antigen tests tend to be rapid, they tend to be point of care, and they tend to be cheaper. And then next slide. So this is showing the kind of the pretest probability and how that factors into the test results. The basic concept is if pretest probability is low because the population prevalence is low, or because you're testing a population, for example, without symptoms, then your negative predictive value is going to be high, but your positive predictive value is low. So if you get a negative, you can be fairly confident in that population. If you get a positive, there's an increased likelihood that could be a false positive. And then,
so just as a question, so for example, if a school was going to use this, if the kid was negative, they could pretty safely assume the kid could go to class. A positive would have to be verified some other way.
Generally, yes. That's kind of the general concept. But again, we have concerns about using these in kids and people that these tests aren't necessarily validated in. So
we did have a question. I'm going to try to catch up on some of the questions coming through. Thank you. But on this particular one, we got a question. Could you please discuss what you know of how the 1.5 million Binax now tests purchased by the federal government will be used?
So it's 150 million. And it sounds like it's going to be about 50 million a month. All I know is what I've seen in the news, because I haven't heard directly in Oregon how it's going to be deployed yet. But what we've heard, this just came out a couple days ago, is the head of the U.S. COVID testing efforts said that they will be sending them starting in mid-September to states. And I think the plan is, again, mostly actually to schools and daycares, but also some long-term care facilities. Also, some tests will be sent to first responders, people displaced by some of the wildfires and the hurricanes. And I'm not sure if the app is going to be part of what is recommended, but the company did develop that app.
So I think, rest to be assured, we are still catching up with this news that was recently released by the federal government, and are looking closely at this, the opportunities, but also the limitations, and we'll be forthcoming with ongoing information in our guidance about how to address the use of these tools.
Yeah, thank you. That's exactly right. And I should say that we here at Public Health have been evaluating these new tests as they come out, and evaluating how antigen testing can play a role in our overall strategy. There's a lot of talk nationwide about how we can use antigen tests to test everybody at home, for example. There really aren't any tests that we would have confidence in, or that are even available at this point, that could serve for actual home screening on a daily basis or a weekly basis of asymptomatic people, as some people are advocating for. And I don't think that would necessarily be a bad idea, but I think we need to see what the test availability is and what the characteristics are before we can advocate for anything like that. So we're still focused on testing the people who are sick, and then some limited screening in high-risk populations.
Stepping back just a little bit, there were a couple questions about the seroprevalence study.
Okay, yeah.
One question was, I'll put them out there, and there's a couple levels to this. So there's a question about whether positivity might change with co-infection with flu, and will these seroprevalence studies be continued periodically? And what about a plan for validation with PCR testing? Has or will this been done yet? And then the other question was just a little bit more about how we were able to make the authors were able to make a statement that that it was 10 times more than the actual test diagnosed during the time, just the time period of it.
Oh yeah, so that statement was based on the number of reported cases that we had, and so just as a reminder, an antibody test does not count as a COVID case because we can't say when that person might have been sick. So our COVID reporting is based on PCR testing as well as any antigen testing at this point. So that 10 times factor or estimate was based on the number of cases that we had reported to us based on a PCR test mostly during that period versus the estimated population prevalence from this sample, which was 1%. So another way of saying that is during that period, about 0.1% of Oregon had a positive PCR test. And so that's where that 10 times factor came in. And sorry, you had a couple other questions in there.
Just about any other plans about validation with other testing tools for the seroprevalence, the participants or the specimens, perhaps, with regards to PCR or antigen testing. Has this been done or will it be done?
Well, as I mentioned, the serology test that we used was one that had good sensitivity and specificity, had a very good large validation test done by the manufacturer, and I'm not sure to what extent it's been validated in other populations. Comparing it to PCR is a little challenging because for most of those people were not seeking care, and I should have emphasized this. Most of those people were not seeking care for COVID or COVID-like symptoms. They were just people who were interacting with the medical system and had blood drawn. So that's why it was a random sample, which was important for the study. But we didn't, many of them may not have even had symptoms at any point, and they never sought healthcare for COVID. So we don't have any way of getting a PCR to compare for the antibody test. So, but I think the test is good enough that it is a valuable data point to look at, and it's pretty much the best we have at this point.
Great, and one other, and then we'll try to keep catching up here. A couple of questions around the disproportionate impact data that we shared. Someone noted that while there's a disproportionate impact in terms of case rate, particularly as an example for Latinx community, that the case fatality rate was actually lower for that population. And so that's accurate. We know that the impacts of COVID, the SARS-CoV-2 infection on the Latinx community has been quite large. Fortunately, the case fatality rate has been lower in that population. Dr. Jean, do you have any comments on what we're thinking about why that might be?
Yeah, if you break this down by ethnicity and race, you have different subgroups that have different age distributions, and that's one of the major factors. Of all these groups, probably the white group has the oldest age distribution, and that's a big factor in why the case fatality is higher for that group, because we know that older people tend to have more comorbidities, and that's a really important factor in severity of COVID. So one thing that we've been planning to do, but we haven't had the resources to do yet, is a little more of an age adjustment to see the relative burden. But the important thing, when you adjust for age, you're taking the true rate and you're distorting it to try to eliminate the influence of age, which is helpful in one sense, but it's also we also want to look at the actual rate, which is what's reported here. So even though we know in Hispanic, Latino, Latinx people, we have a very, very high case rate per 100,000, you can see their case fatality is low. And yes, that's probably related to the fact that they tend to be have a younger age distribution, but it's still the truth that they have a lower case fatality, which is really good news. So I think the most important point is here, we don't want any group to have such a high rate, and we don't want a disproportionate impact of COVID-19 in terms of who's even getting it, let alone getting hospitalized or dying. So that's where we need to work on.
And then just one more on this topic, and I think we'll move on and catch up where we can. There's a question about whether we are working on other improvements in displaying race and ethnicity data with regards to trends in community outbreaks, which are resolved, where are there still ongoing concerns across community. And I would just say, obviously, Dr. Jean just spoke to some of the data challenges, but we are in our weekly report showing trend lines in terms of new cases by race and ethnicity over time. They're not based on population levels, are based on actual number of cases, but it at least gives you a trend line to see impacts that are happening across the state over time. And of course, we do report on outbreaks, but we don't give more detail of specific outbreaks in population. But we know that agricultural, for example, and outbreaks among seasonal farm workers, migrant farm workers continue to be high and impactful. So we're always ears to see what other data would be useful, but take a look at the weekly report and hopefully some of those trends are useful in understanding.
Right, and we are looking at more ways to display that data, but it's, we often run into small numbers problems. If you're doing this on a weekly basis for a population that is a small subgroup, there are just concerns of confidentiality, and it's also less reliable because the smaller the group, the more variability there's going to be and kind of more noise and when you drill down like that.
Great, some great questions coming in. If we don't get to answer some of them today, we'll loop them back in for our future webinars. But let's move on, and then we'll come back to some of them as we can. So we're going to provide a little bit of updates on national guidelines. I just wanted to provide you this information here. There was some, I guess, lots of communication happening after the CDC released their isolation and quarantine changes in terms of timeline. That probably goes back now a month ago. And there was some question by folks at the time that they updated that protocol from stepping out of the need for when you can step down from isolation and quarantine, and if CDC was suggesting that reinfection was not possible at that time. So there was some response from the CDC that you can see here, basically saying that they were not suggesting at the time that reinfection could not be happening. I want to, you can look at the trends in this communication that I outlined on this slide, but as you know, there's been a lot of news about reinfection since then, and Dr. Schmitz is going to walk through what we've been hearing in the news and in the literature since then.
This is just a super quick slide so that, as Dr. Harganani mentioned, that the CDC was not thinking that there was the possibility of reinfection within 3 months. There was a study that was just published this week about a Hong Kong resident, but there was 142 days between his infections, and they were different viral genomes when they did the viral DNA tests. Then there's been press reports. They're not peer-reviewed yet. They're still out there. There's a 25-year-old Nevada resident who became ill a month apart, and his second illness was more severe than his first, and the genomic testing showed different strains. And in the last day or two, there's been 2 new reports out of Europe showing the same thing, people getting reinfected within a month or 2 with different genetic strains. I don't think it's common, but it has been reported, and this is something that's research. We wouldn't be doing the genomic testing on a PCR specimen, for example, so we wouldn't know if someone was positive. Again.
Great, and Dr. Jean, do you want to talk just briefly about healthcare provider return to work updates?
Yeah, so this was a little while back now, but there was a change in the CDC guidance, and we have mirrored that change in terms of when healthcare personnel who have been infected can return to work. And so this is based on the evidence to date, which shows that after 10 days, it's almost impossible to find anybody with replication competent virus. And the exceptions would be people who are immunocompromised or have a really severe illness. And so the two recommendations are for those with mild to moderate illness who don't have immunocompromise, the return to work is now at least 10 days after symptoms first appeared and at least 24 hours since the last fever without the use of antipyretic, and symptoms are improving. So that is basically a change from 24 hours after fever, from 72 hours after fever to 24 hours after fever. And then for those with severe or critical illness or those who are immunocompromised, it's 20 days. It's at least 20 days and up to, at least 10 days and up to 20 days after symptom onset, and consider consultation with infection control experts. So that's specific to healthcare providers, the return to work guidance.
Dr. Jean, I know we've had this question in the past, but who can give the return to work? And we've said in the past that you need to go through your local public health department and not through your private provider. Is that still the case, or?
I think generally for healthcare workers, they're going to be working with their occupational health and infection preventionists. Yeah, so and sometimes they may consult with local public health, but traditionally they have the expertise in-house to make those decisions.
Great. And I think for providers working out in a clinic or a small private practice, can generally follow these guidelines, but consult with public health if there's questions or the scenario is not clear.
Right. Absolutely. Absolutely.
Okay, some literature updates that we're going to share, and again, I'll spread some questions throughout.
Sure. So this is a WHO rapid appraisal that was published 2 days. It's rapid. It was actually in JAMA yesterday, but they had a preview of it on September 2nd. Next slide. This is looking at corticosteroids. They found 7 randomized controlled trials of about 1,700 patients. These are all critically ill patients in 12 different countries. They were given a variety of different steroids or usual care, and there was a significant decrease in the death rate. It's been reported in the press as a 1/3 drop. Of course, there's a confidence interval, so we're not sure, but definitely a significant reduction in mortality for those who've received the corticosteroids. So for your critically ill patients, that's a really important thing to be aware of.
I'll take this one. So this is a study of, we'll briefly highlight a couple studies here. This is one from JAMA in August. It was looking at 18 infected women who had SARS-CoV-2 and looking at their breast milk. So again, 17 of them were symptomatic, and they collected 1 to 12 breast milk samples per mother with a total of 64 samples. This was back in the spring. And they were only able to find 1 sample with detectable RNA from the virus using PCR. But even in that sample, the viral culture was negative, so they could not actually grow any competent virus. They also kind of mimicked the pasteurization that would happen for a milk bank. And so even when breast milk was spiked with the virus, the pasteurization was enough to kill the virus, and they could not culture it after that. So overall, it's a small study, but these findings are encouraging, suggest that breast milk is not a major transmission means for the coronavirus. Next, this was one that we were also going to present last time, but this is certainly relevant still. Plans of U.S. parents regarding school attendance for children in the fall of 2020. And this was a national survey that was conducted back in June. Next slide. They basically did a survey of over 700 parents of kids, school-age kids, with pretty good representation of Black and Hispanic families. And the main finding was that 31% said that they were planning to keep their kids at home, and 49% planned on sending their kids to school. Only 29% of the parents were confident or very confident that their child's school would be able to prevent students from spreading COVID-19. And then some of the other factors involved were socioeconomic status, medical vulnerability, worry about COVID-19, worry about the multi-system inflammatory syndrome, homeschooling difficulties, and confidence in their child's school. So that was just kind of a general sense of what parents were thinking in the summer about school attendance. And then the next slide, please. Overall, lower SES was associated with wanting to keep kids at home. So the take-home point is that under-resourced families need more wraparound services to ensure that their kids can access school equitably. And the link is right there for you.
I think I would just say, you know, obviously school is starting right now. And I think we're going to learn more as different parts of the country and of course the world are engaging in school. And as we see, hopefully cases continue to fall, of course, these feelings might change. And this is a critical factor for all of us to be paying attention to meeting the needs of families and so forth. So thanks for sharing that one. Dr. Smith?
I just wanted to bring an update. We've talked before in these webinars about the poor outcomes for ICU patients who with COVID-19 went up in the ICU. Next slide. I just wanted to bring you a little bit of good news. It looks like based on a new systematic review of 24 studies that actually the mortality rate is coming down. It was above 50% in March and then below 40% by the end of May. So just some good news. We're learning some better techniques and getting better outcomes.
And I would add, you know, even since the end of May, there's been, you know, more understanding of the role of corticosteroids as well as the availability of remdesivir. And so hopefully that trend line is continuing for the better.
Yes. All right, and then what's been in the news a lot in the last couple of weeks is convalescent plasma. This is the therapy where a patient who has recovered from COVID-19 donates plasma and the antibodies are removed and given to a patient who is sick with COVID-19. And I wanted to just kind of run through the data on this real quick. It just got FDA approval, an emergency use approval this past week or maybe late last week. So definitely you're going to be hearing about it. So Cochrane has a living systematic review. This is sort of a systematic review that they're updating as they find new things coming up. The most recent update to this one was sort of mid-July. They included 20 studies, only one was an RCT, and I actually pulled that individually. We'll see that in a second. A total of about 5,443 patients. And all-cause mortality at hospital discharge, they were very uncertain that this had any effect on that. So it didn't seem to affect mortality. Go ahead. Next slide. It didn't seem to affect time to death, and it didn't seem to affect improvement in clinical symptoms or need for respiratory support. So, and then they had some serious outcomes, including 15 deaths, four of which were classified as potentially, probably, or definitely related to transfusion. And as you'd expect, most of those were anaphylaxis or transfusion-related lung injuries and those types of things. So basically, their conclusions are we're very uncertain whether convalescent plasma helps, or they couldn't even say whether it really hurt either. If you want to go into the next slide. So this was the study that I pulled out. This is the one RCT included in that living review. Lee et al., they had 52 patients that received convalescent plasma and 51 patients who were controls with standard therapy. And they had no difference in 28-day mortality or time to discharge. But they did have 2 adverse events that required supportive care.
And, oh, keep going, sorry.
And then this was just another study that was just recent, that just came out looking at the safety, and that they did say that it was low, less than 1%. These were either transfusion reactions, thrombotic events, or cardiac events. The 7-day mortality rate was 13% though, which was more among critically ill patients than less ill counterparts. Although it looked like this was just a convenient sample, so we're not sure really what they were comparing these to or not. So I'm not sure how much it really reflects on safety, but it seemed to have a lower number of serious adverse events than they found in the Cochrane Living Review. So overall, no real data telling us this is helpful. maybe a safety signal, maybe not, that it might be harmful. So just to be aware of that if you're going to be using this.
Yeah, and an RCT is was interesting because it looks like it maybe was underpowered because they found an OR of 0.59, but the confidence interval is so huge that it was not significant. So a little unfortunate, but yeah.
And I believe the NIH and NIH committee has recently reviewed this data and had similar findings that they felt there was really no evidence to support. So
it's hard because if for untested therapy, you don't want to, you don't have the funding or time to do a huge study. So.
And we have used convalescent serum for other conditions successfully in the past, so there's reason to hope that it might help.
Right.
So I'm going to bring up a couple questions that I've seen come up here that I think are hot on the topic of testing, as usual. So the first question, going back a bit, is with regards to the new CDC testing recommendations and whether OHA is changing our guidance. Let's start with that, Dr. Jean, if you want to comment on that.
Yeah, we've gotten lots of questions about this. So just as a reminder, the CDC change, I think it was last week. Days are flying. I think it was last week. CDC changed their recommendation about testing of asymptomatic contacts. So people who've been exposed to somebody but didn't have any symptoms. And they basically are advising against that, or at least saying it's not recommending it. So our investigative guidelines, which is what our local public health and all our epidemiologists follow for COVID, have actually never recommended for or against testing of asymptomatic contacts. And the one thing I just want to highlight, and there's all this talk, continues to be all this talk about how testing is their way out of this. Isolation and quarantine are what matter. Like that's what, and obviously there needs to be some testing involved. But if somebody is a contact to somebody who's a known case, they need to quarantine. And if they were to get a test, they had no symptoms, they decided to get a test anyway, and that test was negative, they still need to finish their quarantine. And that quarantine is the most important thing because we know there are false negatives. So we have never actually recommended that a contact without symptoms get tested. During that quarantine period, if they develop symptoms, we definitely recommend they get tested. Now, the flip side of that is our clinical guidance, our guidance for clinicians says that people who are contacts without symptoms can be tested. And so we leave that up to the healthcare provider's discretion. If somebody comes to you and says, hey, I was told by public health that I've been exposed to somebody, I really want to get tested, that's certainly reasonable to test them with all the caveats about how to interpret the results. So it's certainly something that can be done, but we have those kind of two differing guidance because they have different audiences and different purposes. But again, the most important thing is to finish a 14-day quarantine if you are a known contact of somebody. So I hope that answers that question.
Great, and a couple more we're seeing. I'm going to start and move through. There's a question about PCR testing, then antigen testing, then serology. So I'll walk through it. The first question relates to the Oregon State University TRACE study. They're testing people randomly with PCR tests and asking if OHA is working with these colleagues to better understand the burden of COVID-19.
Yeah, we had talked with them a lot a little while back and earlier in the summer. I actually haven't seen their results lately. I know that they were doing weekly or biweekly publications of the results, and I actually haven't seen that. But I think they're focused in Corvallis or Benton County, and so that is useful data. They are using PCR with a nasal swab where they go around to people's houses, I think, and the person swabs themselves and then they collect it. The initial results from it were very, very low prevalence, as would have been expected at the time. But to be honest, I haven't looked at those results lately. So thank you for the reminder.
We'll see what we can find out. I do believe that they were extending beyond their original geographic boundaries and doing some testing in other parts of the state. But we'll see what we can find out, and certainly have been in touch over time with the important work they're doing. So moving on to antigen testing, there's a question about the sensitivity and specificity data from the manufacturer, particularly concern or question that they were using spiked testing for their data that may not translate to clinical use. do we have any other information about its applicability clinically beyond the studies used for the EUA authorization?
Yeah, well, thanks for raising that. That's certainly a concern we share. You know, these manufacturers are required to do some internal validation, but they tend to be pretty small studies with 100 or 200 people usually, and they often use a spiked known PCR positive specimen. But some of these, I just looked at these again, and I don't remember exactly which, but several of these four actually use specimens from people who are symptomatic. In fact, I think they all did. For some of their comparisons, they may have used spiked specimens. The bottom line is, though, we need more validation, like more external validation of these tests compared to PCR in a separate independent study. And it's just the nature of this pandemic with things moving so fast that we don't have that. And as a reminder, the FDA EUA, emergency use authorization, is nowhere close to FDA approval in terms of the level of oversight and vetting that happens. So that's why these are kind of out there with such limited data. So it is a real concern, and I think we need to, especially with the Binax now, which has gotten a lot of attention and the federal government has purchased and will be distributing, we need to see, I think we will see people throughout the country in various states who are validating it and doing some comparisons to see how good it is compared to PCR.
Great. And we're going to run out of time here. I'm going to make one more question for the team to put it out there, and then the other questions we missed, we will try to follow up on for our next webinar. There's just a question about, noting the concern about serology and the recommendation not to use it for case identification, but just still wondering about the utility, particularly in a clinical population, maybe patients who had confusing symptoms, maybe prolonged symptoms over time that didn't have a positive test. What's the utility? Is that changing? Are there newer tests that are more sensitive that are useful from a serology standpoint?
Yeah, well, I think the benefit of a serology test is limited until we know more about the durability of immunity. And, I think at this point, we're only able to say that there may be immunity up to 3 or 4 months. And part of that is because this pandemic has only been around for, in the matter of months. So I think serology will probably become more useful if that holds out, if it turns out there's some immunity that lasts for more than a few months. However, a lot of the common cold coronaviruses, there's 4 of the common cold coronaviruses, a lot of those don't lead to lasting immunity. And that's actually a pretty common characteristic of respiratory viruses that don't cause viremia. They just don't produce enough of a response that they're going to produce enough antibodies that last a long time. It also seems like some of the immunity to SARS-CoV-2 may be more T-cell mediated than antibody mediated. So serology test wouldn't necessarily give you much information about that.
Great. Well, thank you all for your great questions today. Again, we hope that the broadcast worked. I was trying to get those questions out as they were coming in, not necessarily all in the best sequence. So thank you for the questions. And again, all the work that you do is critically important. We will be joining the Project ECHO team again next Thursday, and then we'll be back for another OHA webinar in 2 weeks. So thank you very much, and we'll talk with you soon.